center. Please, this slide change it will come now.
You can take these papers. Good evening, everyone. I'm the one standing between you all and your evening flights or sightseeing, or a quiet evening with a drink or cup of tea, whatever you prefer. First of all, I'm very grateful to the organizing team led by Dr. Jawahar Pillai, and also the Academy of Hospital Administration, Dr. Yashpal, Dr. Shama, and Jan Jagtar, for giving me this honor. Otherwise, I would have enjoyed my quiet Sunday in Delhi. So, no, but on a serious note, thank you very much for this honor. It's been a great pleasure to be here and interacting with you all. My apologies, General Biswas sir. I didn't recognize you that time. I'll be meeting you after this. Good evening, sir. So I won't take much time. I'll just quickly, take you along to discuss with you few of the newer initiatives of the Government of India and try to weave together the entire health systems of the country on which we work. And I looked at the program over yesterday and today. You have tried to address a lot of these issues, challenges, because when you talk of the hospital as such, the hospital is a part of the entire health system. And you discussed about the cadres, you discussed about the financing, you discussed about the administration. So I won't repeat all the topics, but in fact I wanted to attend this morning session also, but I was in Pune until yesterday, and that's why I could come over here only at the time of lunch. So down, okay. Okay, thank you. So this, I think, is well aware to you all. India has a mixed health system with the public and private. And private somehow is concentrated more in cities as such, and they are more in tertiary. Even in the national health accounts which we prepare at NHSRC, 1819, though 1920 is also ready, but 1819 is also shown clearly. The government expenditure on primary care is increasing, secondary and tertiary is reducing, whereas the private health expenditure on primary is reducing as it was less and increasing tremendously on the tertiary health care. So it's tertiary care services which are being provided by by the private providers. The public healthcare system, as it is primary, secondary, and tertiary level, all levels, and eventually what comes to it, that the health being a state subject, the ultimate onus is on the state to implement all the policies. The Government of India, Central Government of India, provides financial and technical support. And just to share with the young specialists or youngsters who are doing their specialization sitting here, it's a sharing mechanism. For the largest states, it's 60-40, 60% by the central government and 40% by the state government. For the smaller and hilly states and northeastern states, 90-10, 90% by central government and 10% by the state government. For all the centrally sponsored schemes, CSS, and for the central sector, of course, the % comes from the central government. So this also you are aware, but what I would like to highlight here is what is written on the left side, health and wellness centers. So this is what now the game changed from 2018, one of the game-changing initiatives. So all these sub-centers and primary health centers are now being converted to health and wellness centers. The target is to have 1.5 lakh till December 2022, and of course further it will be there. These all you are aware. I'm not going to read it. It's just to I've kept this here to flag this important thing of health and wellness centers which are there, and see the number of district hospitals and sub-district hospitals. So when we talk of conversion of district hospitals to medical colleges, I will link it up with public health management cadre also, that how it will be working and where at what levels. So in the urban areas is a lot of challenges. The urban conundrum we are still grappling with. Though another new thing which is now coming up here for the first time is urban health and wellness centers, which is shown here in the red color at 15 to 20,000 population. So that's something new which was not there earlier. And we are also looking at polyclinics. 1 out of every 5 urban PHCs is being converted now into polyclinics with dedicated funds. Where have these funds come from? I'll come to the sources of that later on. So national health policy, again, there's a definition of universal health coverage. No need to read it or look at it. So, but there were few initiatives like free drugs initiative, free diagnostics initiative in 2016. Quality as such, Dr. Jayan Srivastava mentioned, 2013 onwards as an formal national quality assurance program. But 2018 was a time when first time Ayushman Bharat was launched with two components. The health and wellness centers component, which I have just mentioned in the previous slide, and the PMJ component, which is the insurance scheme. So I'll refer to both of these later on. The ultimate aim is to have universal health coverage where there's assured services for comprehensive primary health care and linkages with the tertiary care. And that tertiary care is coming majority from the private as well as the government empaneled hospitals. So COVID realized, and I think though there have been a lot of negatives for COVID, but it could be safe to say that, instead of getting bogged down, somehow people learned from it, and we tried to look at, to create a more resilient health system. So we realized that public hospitals are not fully equipped to handle clinical management of especially critical care patients, and also segregation and all those facilities were not available. So ECRP, Emergency COVID Response Package 1 and 2, 1 basically was for diagnostics and drugs. 2 is the main, one of the, first time the government of India realized that yes, the infrastructure needs a major push. So the ECRP 2 gives a lot of funding for the infrastructure, for centers of excellence, and also of course for diagnostics and drugs. But luckily, we didn't stop there, and the entire health systems, they were reprioritized in the thinking process of at the central government, and also while discussing with the states. So we all realize that there's a need of strengthening district hospitals. We need to establish critical care blocks of 50 to 100 beds, 50, 75, 100, depending on the population of a particular district. We need to provide high quality integrated public health labs. There used to be only state public health labs. This is first time in realize that yes, we need district public health labs and even block level 2. And infrastructure again, ICUs, HDUs, centers of excellence, and all, even including pediatric ICUs. And environment for studies and all, one health approach. So and including branches for the NCDCs and NIVs. So that's why the token to total approach has been taken. The 4 pillars of Ayushman Bharat, if you see. In 2018, as I mentioned earlier, health and wellness centers and PMJ. On the right side, if you see the digital mission, which Dr. Uma Nambiar mentioned and explained in detail. What is important now here, for which I'll be taking some more time on this, Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, the largest infrastructure mission ever launched by the country. And what all it entails, I'll go through it in slight detail. But coming back to the HWC and PMJ, so if you see that kind of continuum of care is now being built into, we are upgrading the sub-centers and PHCs into health and wellness centers, and we are going beyond illness, we are looking at wellness also, and financial protection of 5 lakh per annum to 40% of the vulnerable and low income. Just to inform you all, we are now discussing with Niti Aayog to look at the missing middle, that how 40% more of Indian population can be included in the scheme. Do we need to, they pay per episode, or we need to take some kind of insurance mechanism for them? Because the private insurance sector insurance is increasing from 17-18 to 18-19 increased from 6 to 6.3% of their share in health expenditure. Whereas the government social sector increased from 6 to 9% in within 1 year. So the government is spending much more on social protection for the community, for the country as such. So this, I think, again, no need to explain this, but then an important point is the unmet need of NCDs and other chronic diseases, eye, ENT, oral care, palliative care, elderly care, mental illnesses, and entire NCD screening of hypertension, diabetes, and 3 cancers, oral cancer, breast cancer, and cervical cancer. All these are now being, have now been, the capacity building is going on, these packages have been, packages are being launched, and by October, we hope that all facilities will be fully functional for this. So that is one additional which has been done now when we converted them to health and wellness centers. And of course, the gatekeeping mechanism and linkages with the PMJ mechanism, both for public as well as private health. So primary health care is no more primary health care. Now it is comprehensive primary health care. So we're looking at expanded package, which I mentioned earlier. Continuum of care, I've already mentioned. Expanded HR, first time we have a community health officer is a leadership position at the health and wellness center. Earlier we had only AIIMS, so 1 male and one female multi-purpose worker. Now we have CHO plus 2 of these. This could be 2 females or 1 female, 1 male, but definitely 1 female has to be there. And expanded, if you see the number of tests and medicines which have to be made available. So yes, the mechanism have to put in place to ensure that the drugs are available and monitoring and evaluation is done. But this is the number of tests and drugs which are being now made available at the periphery. Guidelines and conduct of research for evidence building, from very implementation research, health system strengthening. We have a platform by NHSRC with adequate funding. And community mobilization and health promotion, you involve the community. So from the R case, we have moved now to Jan Arogya Samitis when we talk of these health and wellness centers. At the sub-center and PHC level, instead of the R case, we have now created Jan Arogya Samiti, where the community has voice in running the system as such. And of course, IT systems and infrastructure. That's why space for OPD and also wellness. That's where the money or infrastructure is being spent. So continuum of care, there's no need to explain this, but the linkages I have already mentioned earlier. This is what is, I think, PM Abhim and 15 Finance Commission grants is 100,000 crores over 5 years, up to 25-26. That's the amount of money which is over and above NHM and all the other centrally sector, other schemes too. So this is, outlay of 64,000 crores for 21-25-26. And I'll just show you the important, what are the components for that. Focus is, as I mentioned earlier, increase the investment in public health, infrastructure. Each district to be self-reliant in surveillance, in diagnostics, and critical care, as well as the clinical care, and also preventive and promotive activities, capacity building, saturation approach for all the activities, and convergence with other schemes and this thing. So these are the components we see on right hand side, the central sector components, critical care blocks in 12 institutions. Strengthening surveillance, that's why we talk of, strengthening our ports. 50 ports, land, sea, air, are being strengthened under this scheme, so that in future, something like COVID, we have better response to begin with from the very beginning. Disaster and epidemic preparedness, again, emergency centers and container-based mobile hospital, pandemic research, branches of NIV, NCDC, and also One Health Institution is coming up. The left side shows what all is being done for urban health, rural health and wellness centers. So this has been divided between this and the Finance Commission. Overall, we are strengthening all sub-centers and PHCs and including urban health and wellness centers. Block public health units. Block public health will have the clinical part, the surveillance part, the lab part, and also the administration management part. So the first time it has been thought that yes, block also should be fully self-sufficient, and of course linkage with the district public health lab, which will be linked with the state public health lab, and a group of some states will also have a branch of NCDC that will be linked with these state labs. Integrated district public health labs, again, that's another important initiative, and critical care blocks, which I mentioned earlier. Every district hospital is going to have a critical care block. 602 in this, but then some other, some of them others are being converted to medical college as it is. So 73rd and 74th amendments to Constitution were done in 1993, 1994. But it's the first time in the history of India, independent India, that the money has gone to the Panchayati Raj institution and urban local bodies for health as such. Earlier, the component of health was very, very minimal to them. It was more of hygiene, sanitation, and water only, not for health as such. So these are the grants, if you see, which is a huge amount. And so rural components is again looking at building like sub-centers, PHCs and CHCs. Block public health units, diagnostics at primary health center, conversion of rural PHC into health and wellness centers, and urban components again, diagnostics and urban health and wellness centers. So first time we have looked at going beyond the urban PHC, going down below the urban PHC into sub-center level. Digital mission, I'll skip this. Dr. Uma Nambiar, covered it very well. So these are the various, that's the entire ecosystem. So everyone has to be integrated into the digital ecosystem as such eventually. And So we are also looking at, when we look at ecosystem of ABDM, we're talking of affordability, safety, timeliness, inclusiveness, accessibility, and efficiency. We're looking at equity through digital intervention. So when we talk of DHIs, which is the buzzword now, and I heard when I saw a presentation of AI too, I had a talk on digital health intervention in IPHA conference of our national conference day before yesterday. So what I mentioned there, I would like to just reiterate that we must ensure that we don't create inequity while using digital health interventions. The cure should not be worse than the ailment. So we need to ensure equity when we talk of digital health intervention. So we need to understand the regulatory processes, the governance mechanism, the capacity building, and also research and development and monitoring and evaluation of these. And of course the integration where healthcare workers also should not be at a disadvantage while using digital health interventions. So it's a topic in itself. I'm not going into it, but yes, as hospital administrators, you must be fully aware of it, all the challenges and what you need to look at. These three are Aadhaar number for every individual, healthcare professional registry for every all health, and health facility registry. So all those, you're involved in administration, you need to register your health facility also, all government as well as private. The websites are being developed. I saw a demo about 2 weeks ago. So that they are functional but not fully as such. So these will be very soon, it will be mandated on that. So there are a few initiatives which I have already discussed. So just to highlight few of those. Free drug service initiative 2016 onwards. So it's not only provision of drugs. It entails strengthening robust system procurement, quality assurance, IT-backed supply chain, warehousing, prescription audit, grievance redressal, IC activities, training, and again, these are all, the diagnostics has, teleradiology initiative also along with the pathology, and also CT scan services in government, the hospitals and technology support. So it talks about hub and spoke model. It also talks of PPP mode. What we say is that all high volume, low cost tests should be done, the capacity should be in-house, and low volume, high cost could be PPP models could be looked at in a hub and spoke model again. And the public health management cadre has already been discussed in the panel discussion also. So I won't spend much time on this, but then yes, the flexibility is with states. And so probably it's a good idea. We will discuss with the government that how to address this health management cadre. So that we'll discuss it again with the ministry. So these are the four major the cadres which we have mentioned. But if you see the right side, the block on the right side, the career progression for each cadre will be distinctive in the respective streams with inherent flexibility for inter-cadre deputation wherever necessary if criteria for qualification are met. And we have given 2 schemas. We made about 5 or 6 schemas basically. So other 4 we were asked by ministry not to share. We were given only 2, but then those 4 can also be shared with the states. So as I mentioned earlier, we are now progressing with more consultation with the states as such. In that we are looking for partners instead of NHSRC conducting it on its own. Public health standards is again, the public health standards for 2007 and 2012 were made at Nirman Bhavan. 2022 were made in NHSRC because we are now the technical body for the entire ministry, not only the NHM. And so this is what we are looking at is service delivery. You see point number 3, this IPHS guidelines if you see, and you can adapt these because we have gone up to 500 bed district hospital. So any private hospital should also probably look at it of the 500 bedded or even whatever, and those same can be multiplied, and you can look at that. The overall aim once a facility is IPHS compliant is a service delivery component. Not only the infrastructure or HR or diagnostics. So that's the difference in approach from previous IPHS to this IPHS, which can be easily used by the private health facilities too. And any facility which is IPHS compliant is quite near the NQAS compliance also. So that's what we said, that there will be no certification for this. The facilities have to self-certify, and then NQAS, for NQAS we have a system as such, and that will follow for the qualification. So coming back to this, I am not going to discuss in detail. You had a detailed presentation from Dr. Srivastav, and also yesterday you had a session on quality as such. So, so you are aware of the journey of the NQAS, National Quality Assurance Program. And so what we are now looking at is partnering with the academic institutions, organizations, institutes of national importance and all, to enlarge our pool of quality assessors. Till now we have been doing the training in-house, but now looking at the requirement and also looking at requirement from many private hospitals also who are approaching us for assessments, and we don't have the capacity right now from our national pool and state pools, because our targets are almost 50% of facilities to be certified by 25-26. So we are looking at now a few partners who will then train, of course, with the some kind of technical support from us and some kind of oversight mechanism and certification by us. So we are working on that. SDGs, I think you all are aware, but then the implementation is a major issue. Digital health I have already mentioned earlier, but again, the equity, inequity, those issues need to be discussed. We are working on various DHIs, and the Telemanas is something which will be rolled out on 10th of October, which was announced in this year's budget. This is where what I have just now said about the governance and regulatory mechanism, capacity building, research development, and also monitoring and evaluation. We took that approach, and on the entire health systems approach while designing this T-Manas. So let's hope we are able to reach out to all those who need mental health services. 80% of those who will call, that's what our premise is, will just need some counseling rather than any kind of treatment. But we are linked it with the National Health Program or District Mental Health Program too. But integration is the buzzword, and I've now got the mandate to hire the IT advisor and 20 people for creating a new IT division, and within a month or two that will also be functional in NHSRC. Oh, I think I'm going back in this. Okay, sorry. We are not, when you talk of DHIs, it's not only what we are doing for patient care or preventive, promotive and all. Capacity building of healthcare, and there's a discussion about the capacity building in the hospital administration. So this is a portal which we have launched recently. We are looking at whatever capacity building we are doing. What are the numbers we are doing? Not only that, we are going beyond. What is the quality? The quality of trainers as well as trainees. And the second model, which we will add to it later on by next year, will be also look at the skill of the trainees. What skills have they acquired? So we can leverage technology by utilizing this. This portal, Dr. Srivastava has already referred to. Saksham and also Sakushal, which has just been launched on the World Patient Safety Day this year. But yes, challenges are there. Deficient health infrastructure, the deficient health workforce, high out-of-pocket expenditure. But again, it is a tremendous drop in out-of-pocket expenditure. It was 65% of total health expenditure in 2013-14. As per 18-19 national health accounts, this is 48.2% of total health expenditure is out-of-pocket expenditure. There's a tremendous drop within 6 to 7 years. And 19-20, I can't share with you, but again, it is reducing further. So it is reducing because of various initiatives. Our target is to bring it to up to 25% of the total health expenditure, which is a big ask, but then we are working towards that. Look at urban-rural disparities, social disparities, and also intersectoral convergence. So, way forward, in this August gathering where I am with the seniors of hospital administration and your experience from government as well as private and also working at various levels. So policy making, that's where the association can also work with us. So it's a larger social, economic, political context where we can work together and give our feedback to the Ministry Nirman Bhavan, because we start the process and then we get inputs and then we have consultative meetings. That's how we develop the policies developed. Strengthening healthcare facilities. Again, India's COVID response I've already mentioned, and increase health expenditure. But then again, these percentages are misnomer, because this year, if you read the recent national health accounts of 18-19, 1.28, last year it was 1.35. So in reality, what has happened is the numerator has increased by 5%, the denominator of our GDP has increased by 12%. So we have to now go beyond statistics and look at the actual amount which is being spent rather than only the percentages as such. So this is another, I think, important issue what I have flagged for hospital administrators. The district hospitals are being converted into medical colleges. So what happens to the functions of district hospital as such when it is being converted to medical colleges? So the SDHs take over, that needs to be strengthened. And that's again an area where the hospital administration again play a role. The medical colleges which are coming up in district hospital, they're not only they're running as smoothly as such, even their training and teaching inside in those hospitals, in those medical colleges, because that is severely right now compromised in except very few good examples. Supply chain management, again, that's another area which needs a lot of attention, even though with a lot of efforts from DVDMS and other using IT interventions. But supply chain management, that's where you have core competence and you could work with us to strengthen the supply chain management. To begin with, we can have a study which we are already thinking about. So that's one area where we need to understand more. Infrastructure normative target to reach underserviced, that's already there. Ensure accountability, and that's what I mentioned, 1,000 odd crore plus for 5 years only for these two schemes. So their implementation and like critical care blocks. States are though guidelines have been given and they were made in consultation with them. We recently had 5 workshops, but still states need some experts to work with them to ensure that the critical care block is made properly. The district public health lab comes up properly. The block public health unit comes up properly. The pediatric ICUs and all come up properly. So they're designing their efficient functioning and utilization, even procurement of equipment for that. So that's where I think the hospital administrators have got a major role. And your expertise is required to work with the state team, sit with them and ensure that this is, they purchase the right equipment and the infrastructure is also appropriate. So this citizen participation, I've already mentioned about JAS and how we are involving the communities. green and climate resilient. That's again for all the hospital administrators here, that we need to look at the impact of climate on health, and impact of health sector on climate, because health sector is a large contributor of all these activities too. So we need to look at IPHS adoption that includes rainwater harvesting, solar energy. We are looking at both two models, the on-grid model and off-grid model. So those can be discussed upon. Decentralized energy partnerships also can be explored with the private sector as such. So private sector involvement, PPP mode. The hospitals are being empaneled under PMJ, yes, definitely. But again, the outsourcing, insourcing of the services. There's a document on our website where we have reviewed the public-private partnerships since the inception of NHM. If anyone interested, please go through that, where we have seen what were the challenges, how many of the PPPs did not succeed, and what is the way forward. So that's where we have written clearly how these PPP models can be made, and I would request all those working in private sector to look at that, so that you can have proper, good partnership with the government sector as such. Technology already been discussed, HMIS and alternate streams in sectoral convergence. This last slide, a few words about the NHSRC. I think most of you are unaware what is National Health System Resource Center. So I have these technical divisions under me. Each one is headed by an advisor. There's a community process in comprehensive primary health care, which looks at all these ASHA program, the sub-center and PHCs, health and wellness centers, and also all the preventive, promotive, the services and capacity building of the workers in this sector. Healthcare financing looks at the national health accounts, which is comparative with all entire world. We are now working with states. Target is 12 states in this financial year only to come up with their own health accounts. And you need these health accounts to know what are the sources of revenue, what is it being spent upon, who is spending it, and how what is the actual net utilization of this. The healthcare technology looks at entire technology within the government public health systems as such, their technical specifications, and also health technology assessment and health technology. There was a statement made by someone that HTA, ICMR is not doing. I would like to correct that. We are doing a lot of work. I am also a member of that committee. We keep on evaluating all the health technology assessments and all. And in fact, a lot of studies are being carried on. Anyone interested also can put up a proposal, and we can discuss that. HRH and Health Policy Integrated Planning, that division looks at the program implementation plan which comes from states. The Public Health Administration looks at the secondary care services and also rules and regulations. And knowledge management looks after the implementation research, health system strengthening, and also knowledge management for the entire health system. Quality and patient safety, you are well aware, and Dr. Srivasta's talk covered it. IT division is now coming up. I have a branch in Guwahati, which mirrors these divisions with small number of people. And we are now in expanding mode. We're going to 20 of this IT and plus 45 more positions. So the total will cross 300 over next 3 to 4 months. So all the youngsters who are doing the MPH or MHAs and all, keep looking at a website and see if the job something interests you. So this is the last one, of course, partnerships. We are looking for partnerships with institutes of national importance, medical colleges, AIIMS, organizations, associations like AHA, IAPSM, IPHA. So what we would like you to get involved is implementation of the PM ABHIM Finance Commission grants, IPHS 22 certifications, public health management cadre. So there we can have consultative workshops to begin with, and then nominate state-wise who will work where, and that kind of, so that we ensure that there's an efficient and effective utilization of these grants. And whatever cadres are made by HMC, for example, those are fully functional and well thought out, rather than just coming up with a notification and not following it up. Implementation research is another area where we all can work together, and technical consultations of policy making, where we call experts for consultations, and that's another area where we can formally work together. With that, I will stop here, and thank you very much once again for giving me this opportunity to be here with you, amongst you. I'm from a specialty which felt threatened when the hospital administration started coming up, but then there's a space for everyone. There's a public health, there's a health administration, and now there's a family medicine which is also coming up. There's a space for everyone as long as we excel in our jobs and we understand our roles and we integrate with each other and work together for the betterment of health sector. Thank you very much, ladies and gentlemen.
Cover and every district medical college. Already all medical colleges are not having faculty members. As per NMC, we are not having. 6-7 medical colleges are in Haryana. And our CM is announcing that in every district we will make medical college. So I cannot understand how faculty we will cover.
Good. Good question. And that's why I mentioned this over there in red also, I mentioned separately, that it was announced by government that every district hospital will be converted to medical colleges. First issue which I flagged here was that what about the functions of district hospital as such, who will do that? Second, which I did not flag, which you have flagged, is what is the requirement? So for that, I think we need to go back to the government, and that's where the voice of the associations. I discussed with the IAPSM and IPHA also, even with FOXY and IAP. So we are working on it, and we'll request AHA also to come up in that. We need to make some kind of a document where we need to make sure that, see, the Niti Aayog has given a requirement of the number of doctors. They made projections. Based on that, this statement was made by the Honorable Pradhan Mantri, and a policy was made that every district will be converted into medical college. But we know the challenges. That's why I mentioned very clearly, barring very few, the teaching and training needs to be addressed. So I think this is a much larger issue than only discussing here and solutions. Since the policy has been announced, we need to go back to the government with some kind of statistics, that this is what the current is, and probably we can do it in a phase.